Welcome to This Week in Endocrinology. This week we're covering 10 notable papers spanning the expanding cardio-kidney-metabolic reach of incretin therapy and weight loss, adrenal and pituitary disease from diagnostic testing to targeted oncology, and the long shadow of dysglycaemia across pregnancy, liver disease, and rare growth disorders. Let's dive in. We begin with semaglutide and the question of how far its benefits extend beyond glucose and weight. In the Lancet Diabetes and Endocrinology, a pre-specified pooled participant-level analysis of the SELECT, FLOW and SOUL trials brought together nearly 31,000 participants, followed for roughly 3 to 4 years, spanning people with chronic kidney disease, people with atherosclerotic cardiovascular disease, and people with and without type 2 diabetes, and using both injected and oral semaglutide. The primary composite of a persistent halving of estimated glomerular filtration rate, kidney failure, kidney-related death, or cardiovascular death occurred in 973 semaglutide-treated participants versus 1,134 on placebo, a relative risk reduction of about 16%. The narrower kidney-only composite, stripping out cardiovascular death, fell by roughly 20%. Safety was in line with the wider GLP-1 class, and serious adverse events were numerically lower on semaglutide. The author's interpretation is worth sitting with. Benefit appeared consistent across the cardio-kidney-metabolic spectrum, regardless of baseline characteristics, which argues that kidney protection is not simply a downstream consequence of better glycemia or weight loss. Practically, this strengthens the case for considering semaglutide as organ-protective therapy in patients with cardiovascular or kidney disease, not only as a glucose-lowering or weight-lowering drug. Alongside this, the same journal published Step 12, a Phase 3b trial of once-weekly semaglutide 2.4 mg in 242 adults across mainland China and Taiwan, recruited using locally defined body mass index thresholds as low as 24. Over 44 weeks, weight fell by about 12%, with semaglutide versus just over 2% with placebo, a treatment difference of nearly 10 percentage points, and 80% of the semaglutide group lost at least 5% of body weight, compared with 24% on placebo. Gastrointestinal side effects dominated as expected. The clinical message is that efficacy in an East Asian population with lower body mass index thresholds mirrors what we have seen in Western STEP trials, supporting treatment decisions based on population-specific adiposity criteria rather than a universal cutoff of 30. That leads naturally into a paper in Diabetes Care that reminds us weight loss achieved without pharmacotherapy carries decades-long dividends. The Daqing Diabetes Prevention Outcome Study followed 540 Chinese adults with impaired glucose tolerance for 34 years, grouped by weight change over the initial 6-year lifestyle intervention. Compared with those who lost no weight, those who lost at least 5% had roughly a 44% lower risk of cardiovascular death, a 29% lower risk of cardiovascular events, a halving of heart failure hospitalization, and about a third lower all-cause mortality after adjustment for age, sex, and baseline weight. Median time to cardiovascular death was delayed by 6.5 years. This is observational within a trial cohort, so causality is not settled. But the size of the signal makes an important point for the clinic. Modest early weight loss in prediabetes is not a cosmetic endpoint. It is a mortality intervention, and the window matters. Staying with dysglycaemia across the life course, Diabetes Care also published a large retrospective cohort from Kaiser Permanente, Southern California, covering more than 326,000 mothers and 442,000 pregnancies, followed for a median of just over 6 years. Gestational diabetes was associated with a nearly 6-fold higher risk of subsequent diabetes, and recurrent gestational diabetes with a roughly 10-fold higher risk. Asian women had both the highest rates of gestational diabetes, around 20%, and the highest recurrence rate, over half, and the highest post-recurrence diabetes risk, close to 12-fold. The actionable point is that a second episode of gestational diabetes should trigger a materially more intensive surveillance and prevention plan than a first, and that ethnicity-specific risk stratification belongs in postpartum follow-up. Complementing this, a pragmatic review in the Journal of Clinical Endocrinology and Metabolism tackles diabetes and cirrhosis, an increasingly common convergence as metabolic dysfunction-associated steatotic liver disease drives the cirrhosis burden. The authors highlight that hemoglobin A1C is unreliable in advanced liver disease, favoring oral glucose tolerance testing and continuous glucose monitoring. Metformin remains the backbone in compensated disease. GLP-1 receptor agonists and SGLT2 inhibitors are attractive where steatotic liver disease and cardiorenal comorbidity coexist. Sulfonylureas and agents causing fluid retention should be avoided as hepatic reserve falls, and insulin with conservative, dynamically titrated dosing is the main. The overarching principle is hepatic safety over rigid glycemic targets. Turning to the adrenal gland, two papers address very different problems. The CHIR-ACIC trial in the European Journal of Endocrinology randomized 48 patients with unilateral adrenal incidentalloma and mild autonomous cortisol secretion to adrenalectomy or conservative management. Having previously shown benefit for hypertension, the investigators here report that the metabolic and quality of life story is far weaker. There was no statistically significant improvement in anthropometric or metabolic parameters. 21% of surgical patients lost more than 5% of body weight versus 4% managed conservatively, with confidence intervals crossing 0. Glycemic status improved in 44% versus 33%, again non-significant, and quality of life change did not differ between groups. This is a small trial, but the honest reading is that surgery for mild autonomous cortisol secretion should not be sold to patients on the promise of weight loss, better glycemia, or improved well-being. Also in the Journal of Clinical Endocrinology and Metabolism, a multi-center Korean common data model study of 307 patients undergoing saline infusion testing for suspected primary aldosteronism derived a decision tree from screening variables alone. A phenotype of plasma aldosterone above 25 nanograms per deciliter with suppressed renin predicted a 96% confirmatory test positivity rate, while in the intermediate aldosterone band, potassium at or below 3.9 further stratified risk, and low aldosterone predicted low positivity. Overall accuracy was 0.85, outperforming rigid conventional cutoffs. In keeping with the 2025 Endocrine Society probability-based approach, this supports omitting confirmatory testing in the highest probability patients and moving them straight to subtyping. Finally, 3 papers on rarer endocrine disease. A review in the Journal of Clinical Endocrinology and Metabolism covers belzutifan, the first-in-class hypoxia-inducible factor II alpha inhibitor for advanced pheochromocytoma and paraganglioma. In the LITESPARK015 phase 2 trial, belzutifan achieved an 85% disease control rate and a 26% overall response rate, with improved blood pressure control and quality of life, and predictable mechanism-based anemia as the main toxicity. It is now the first oral and second approved therapy for metastatic disease, though molecular predictors of response remain undefined. In the same journal, a Swedish nationwide matched cohort compared 348 patients with acromegaly-associated diabetes with nearly 3,500 matched patients with type 2 diabetes. Baseline cardiovascular disease was substantially more common in the acromegaly group, 61 versus 43%, and incident cardiovascular morbidity was about 55% higher, driven by venous thromboembolism, particularly pulmonary embolism, and arrhythmia. Overall and cardiovascular mortality, however, were not significantly increased. So despite the lean phenotype, these patients warrant vigilant cardiovascular and thromboembolic surveillance. And a cohort of 71 individuals with Temple syndrome from United Kingdom and Dutch centers defines the endocrine phenotype of this imprinting disorder. Most born small for gestational age, early feeding difficulties in 87%, obesity in 47%, central precocious puberty in 62%, dyslipidemia in 38%, and confirmed growth hormone deficiency in 27%, despite normal insulin-like growth factor 1 in all. Short stature improved with age, more so with growth hormone therapy. Only 56% met 3 or more Netchin-Harbison criteria, hence the proposed Temple-specific score to prompt earlier testing. If you only have time for one paper this week, make it the pooled kidney analysis of SELECT, FLOW and SOUL in the Lancet Diabetes and Endocrinology. It is the broadest evidence yet that semaglutide's kidney protection extends across the cardio-kidney-metabolic spectrum, including people without diabetes, and it will shape how you frame these drugs to patients and to nephrology colleagues. Here are the key takeaways from this week in endocrinology. Semaglutide reduced major kidney and cardiovascular death outcomes by around 16% across nearly 31,000 pooled trial participants, with benefit apparently independent of glycemic or weight effects. Semaglutide 2.4 mg produced 12% weight loss in Chinese adults recruited at locally defined body mass index thresholds, supporting population-specific treatment criteria. Early weight loss of at least 5% in prediabetes was linked to lower cardiovascular and all-cause mortality more than 3 decades later. Recurrent gestational diabetes carried a roughly 10-fold future diabetes risk, highest in Asian women, so escalate postpartum surveillance after a second episode. Adrenalectomy for mild autonomous cortisol secretion did not significantly improve weight, metabolic parameters, or quality of life, so counsel patients accordingly. And a simple screening stage decision tree may let you skip saline infusion testing in patients with markedly elevated aldosterone and suppressed renin. That's your roundup for this week in endocrinology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary for clinical decisions. Always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.